All right, it is 11:02, so we will get started. Our presenter today is Gabriela Beroukhim from Weill Cornell Medicine, and I believe her attending is on as well. Maybe not yet. Gabriela, do you just want to introduce yourself briefly and then we'll get started?
Sure, of course. I am a second year fellow at Cornell, doing my fellowship in reproductive endocrinology and infertility. Dr. Chapman is my attending and mentor. I believe he should be logging on shortly. I'm going to just send him a quick text message as a little reminder.
And Gabriela, remind me, is it Beroukhim or Beroukhim?
It's the latter, Beroukhim.
Beroukhim, okay.
Thank you.
Yes. And then we have Matt Bolt here as well, who's a statistician here at the University of Colorado and has been providing the stats analyses for all of our journal clubs. And we are eternally grateful to him for that as we all learn something more significant than typical journal clubs where we just kind of breeze through the statistics. So I thank you for that. And then Dr. Turan is here as well, who has been guiding and leading our journal clubs. We'll wait for Dr. Chapman and that we will.
I actually just received a message that Dr. Chapman might still be in the OR. So
Okay.
I'm happy to go ahead and get started if that's okay with everybody.
That sounds great. So Gabriela is going to present the article. Matt will present the statistics, and then we will have a discussion at the end. You may proceed.
Perfect. So today we'll be going over the article Determinants of Transplantation Success with Cryopreserved Ovarian Tissue, data from 196 women of the FertiPROTEKT network. And before we dive into that article and review the specifics and outcomes of ovarian tissue cryopreservation, it's important to consider the broader context. So 70,000 adolescents and young adults between the ages of 15 to 39 are diagnosed with cancer annually. And as survival rates improve, so does the need for effective fertility preservation strategies. So given this growing need, it's important to understand the range of fertility preservation options that are available to patients and how ovarian tissue cryopreservation fits within that broader landscape. So controlled ovarian hyperstimulation with cryopreservation of embryos or oocytes is the method that is most likely to result in a subsequent pregnancy. And oocyte cryopreservation is specifically a viable option for patients who don't have a partner or individuals who prefer not to freeze embryos. The stimulation protocols can typically be started randomly throughout the cycle. However, this process typically takes between 10 to 14 days of stimulation. Additionally, patients can be started on an aromatase inhibitor, particularly if they have a hormone-sensitive malignancy. However, typically, patients who are undergoing controlled ovarian hyperstimulation are post-pubertal. On the other hand, ovarian tissue cryopreservation and transplantation can be done immediately. It does not require a 10 to 14 day approximate period of controlled ovarian hyperstimulation, and it can be done in pre-pubertal individuals. An additional benefit of ovarian tissue cryopreservation is that it can restore ovarian endocrine function for a period of time. However, some issues with ovarian tissue cryopreservation include that it can potentially reseed tumor cells, and that's particularly important for patients with leukemia. And ovarian tissue cryopreservation can sometimes require additional transplants as the tissue is not viable for a prolonged period of time. Other possibilities can include ovarian suppression with a GnRH agonist, And these studies have been performed in patients with breast cancer and is not a form of fertility preservation, but can be performed in patients who are not eligible for other options. And ovarian or uterine transposition can be done particularly in patients who are having radiation to the pelvis. And this can be done through pexy of the ovary, or sometimes it can also be done by complete transposition of the uterus to the upper abdomen. So a little bit of history of ovarian tissue harvesting. This emerged about 25 years ago. So in 2000, it was the first report of restoration of endocrine function from ovarian tissue transplantation. And then in 2004, Octay et al. Reported the first embryo development by ovarian tissue cryopreservation. And soon after, between 2004 and 2005, there were two groups that reported the first live birth resulting from ovarian tissue cryopreservation. And then leading up to 2000 to 2021, there were over 200 live births that were reported after ovarian tissue cryopreservation and subsequent transplantation. So there are some challenges and unknowns regarding ovarian tissue cryopreservation. And those include that up to 70% of follicles can be lost within the first days of grafting. And this is thought to be due to delayed revascularization of the tissue, which contributes to its overall short lifespan and the need for repeated transplantations in individuals. Also, there's some discussion about the optimal graft site, which considers the vascularity, the cosmesis, the temperature, the paracrine factors, the ease of grafting, and importantly, access for patients who will eventually undergo egg retrievals, or the possibility of having a natural conception after grafting. And then, of course, what we're going to be discussing today is information about the potential prognostic factors, which include age at the time of harvesting, exposure to radiation, transportation of the tissue, technique, experience, and results from first or repeated transplants. So prior studies have suggested that the live birth rates following ovarian tissue cryopreservation and transplantation ranges between 24 up to 41%. And factors that have been reported to be associated with success rates include a younger age at the time of tissue harvesting, whether the patient has had exposure to pelvic radiation, and then a question of whether or not transportation of the tissue could be involved with results of success. So that brings us to the study that we're going to be discussing today. And their primary aim was to assess pregnancy and live birth following ovarian tissue cryopreservation performed in the FertiPROTEKT network. And the study also aimed to define factors that were associated with success, whether it was age, first or repeated transplants, experience of the transplant center, overnight transportation, and exposure to radiation. So regarding the setting, FertiPROTEKT is a network founded in 2006 that uses standardized protocols. It is associated with 158 centers, the majority of which are in Germany. And FertiPROTEKT runs a registry collecting data on women who have undergone ovarian tissue cryopreservation, had their tissues stored in about 26 centers, and then a portion of those patients that have subsequently underwent transplantation of that tissue. So the population included there were over 5,000 individuals who underwent ovarian tissue cryopreservation. And of those, 196 women, either with primary ovarian insufficiency or desire to conceive, underwent 244 transplantations up to the end of 2019. And the follow-up concluded in the end of 2020. For their inclusion criteria, they reported that they used ESHRE criteria for the diagnosis of primary ovarian insufficiency, which included a diagnosis of oligo or amenorrhea for at least 4 months, elevated gonadotropins, and a low estradiol. They excluded individuals who had already undergone ART prior to the transplantation, or women who were able to conceive naturally after tissue had been harvested, but before tissue had been transplanted. So with regards to the harvesting and the transplantation, again, all this was done between 2007 and 2020. And the tissue was collected typically via laparoscopy, very rarely via laparotomy, and that was only done if that surgery was indicated for other purposes, such as treatment of their malignancy. All the tissue was harvested without heat coagulation, and in 84% of cases, only 50% of one ovary was harvested. And then that tissue was transported either to a local facility, or in 50% of cases, it was transported between 5 to 24 hours to a facility where it could be stored. That tissue was then incubated at room temperature at the time of transplantation, and it was warmed. It was then dehydrated and rehydrated for the purpose of removing any freezing agents that were around the tissue and restoring normal tissue volume. And then at the time of the surgery, they assessed for tubal patency, and then they transplanted the tissue into a peritoneal pocket in 87.5% of cases. And in the remaining cases, they either transplanted the ovarian tissue onto one ovary on the side that there was a patent tube, or to both of the ovaries. So the primary outcome was to assess which characteristics were most associated with success, looking at factors such as age at cryopreservation, age at transplantation, the duration of storage, the disease diagnosis, the size of the transplant center or their volume, whether overnight transportation was required, restoration of ovarian tissue activity 12 months after transplantation, which was defined as recurrence of regular or irregular menses, a history of pelvic radiation, and the need for IVF. And for the purpose of this study, they were really looking to assess factors that were associated with a live birth or with pregnancy. So they divided the cohort into those who were able to achieve pregnancy and those who were not. And with regards to assessing for age, they looked at age both as a continuous variable and comparing individuals who are less than age 35 or greater than equal to 35. Again, they were also really interested in looking at outcomes for patients after either their first transplant or subsequent transplants. So they also subdivided individuals into those cohorts as well. So briefly, I'm gonna pass over the mic to Matt, who's gonna review some of the statistics of the study.
Thanks, Gabriela. So as Gabriela just said, the primary outcome was looking at characteristics associated with success, and we'll see pretty shortly here a table going over those characteristics and whether or not they're associated. But primarily the way that they answered this question was using t-tests, chi-squared tests, and Fisher's exact tests. These three tests are very standard, straightforward statistical tests that you find in a lot of table ones in the literature, but I'll go over them briefly today. Firstly, most of our study is people broken up. Oh, go back one slide real quick. Sorry. Most of our study is people broken up into two groups, right? There's the women who got pregnant and the women that did not get pregnant. And so with those two groups in mind, if we want to compare continuous variables between those two groups, like age, cryopreservation, or age at transplant, for example, we would use a t-test. And so the t-test is always useful for comparing two groups with continuous variables, or you could say comparing if a continuous variable differs between two groups. The other thing you can do, if you don't have continuous data, if you have categorical data, like the size of the transplant center, if it's small or large, or if they used overnight transplantation, yes or no, those are both categorical data. And to compare if categorical data differs by percentages within the pregnancy or non-pregnant group, you can use something like a chi-squared test or a Fisher exact test. The only difference between a chi-square test and a Fisher-Exact test in this instance is that a Fisher-Exact test is more helpful for use with small sample sizes. Mathematically, they're pretty equivalent, and in the way we interpret them, there's really no difference. Next slide, please. The other method that's used in this paper is logistic regression modeling with natural cubic splines. Initially, the authors see if the ages differ between pregnant and non-pregnant groups in this sample. But an even more nuanced way to do this is to ask the question, how does the probability of pregnancy change with age? And logistic regression is a very common regression tool when you have binary outcomes. In this case, pregnant or non-pregnant are our two groups. And we want to know, as age increases, does that increase or decrease the probability of getting pregnant or not pregnant? Normal standard logistic regression assumes that the relationship between a predictor like age and the outcome, pregnancy, is linear. So in our plot on the left here, again, this is just hypothetical data that I've made up. This is not data from the study, so don't go home thinking it is. But you can see in our plot on the left, this represents kind of a standard logistic regression approach, where our probability of pregnancy and age are linearly associated. And we fit a model that's a straight line, and we assume that the impact of age from 20 to 25 or 30 to 35 or 40 to 45 is always the same impact on the probability of pregnancy. Now, we know that the association between age and probability of pregnancy is probably not linear. There's probably nonlinear relationships going on. And so this is where the natural cubic spline comes in. We can actually fit a relationship that's more curvy. So for example, on the right, I've used something like a natural cubic spline to make this picture. And this basically says that the probability of pregnancy is higher before age 20, and around age 20, it kind of drops over time to age 35 or so. Again, I just made this data up. This is not scientific in any way. And then, maybe the line flattens out from 35 onwards, or even goes up a little bit. And by using this natural cubic spline, we can fit a model that's more curvy in nature and allows for more flexibility besides just a straight line. Next slide, please. The last thing I want to mention about the study, they were very explicit in their methods that they used individuals, not transplants, as their unit of measurement, which is great. Otherwise, they would have had problems with assumptions of independence. And that's a statistical assumption where you assume that all your units of measurement are different and not associated with one another. So you have person A, person B, person C. They aren't like family members. They aren't like, twins or something. They're just independent people. If you use transplants as the unit of measurement in the study, you could have multiple transplants with one person, and this could cause a couple problems statistically. We can think firstly of maybe there's a person in the study that for whatever reason is never going to become pregnant. And if you use transplant as the unit of measurement, they would show up multiple times in your study. And this one individual's effect could maybe kind of overcrowd the sample compared to other people that were only included once because they only needed one transplant. And so I'm just very happy to see that this study uses individuals as the measure. And I want to just note that before we go on to the results so that we can interpret things by person rather than by transplant. That's all.
Great, thank you. All right, so now we're going to move on to the results of the study. So this is a table of the baseline characteristics of the complete cohort of 196 women. And importantly, this data reflects results from the first, or characteristics from the first transplant. So they report that the mean age of the complete population was 31 at the time of preservation and about 36 at the time of transplantation. The tissue was stored for, on average, 4.6 years prior to a transplant occurring. With regards to the disease state of the patients, the majority had a diagnosis of breast cancer or Hodgkin's lymphoma. Of note, there were 5 patients who had non-malignant disease. And 50% of cases required overnight transportation of the ovary. and 65.5% achieved active ovarian tissue after 1 year of transplantation. So again, that was defined as recurrence of regular or irregular menses. 20.6% of individuals underwent controlled ovarian hyperstimulation following transplantation, and less than 10% of individuals had pelvic radiation exposure. So now on the right-hand side, this is where they categorize patients as either having achieved a pregnancy or not, in order to assess factors that were associated with successfully achieving pregnancy. So first, the women who were able to become pregnant were on average younger, both at the time of cryopreservation and also then subsequently younger at the time of transplantation. Patients, again, who were able to achieve pregnancy after the first transplantation were more likely to have active ovarian tissue 1 year after transplant. And the majority of patients conceived naturally in the cohort, which was about 62% of pregnancies. However, pregnant women were significantly more likely to have utilized ART compared to women who were not pregnant. And there was no...
Real quick, can we just slow down on that part there? So active ovarian tissue 1 year after transplantation. So individuals who still had active tissue before transplantation, if yes, then 47% yep, had a pregnancy compared to 4% who did not have active ovaries. Am I seeing that correctly?
Those are counts.
So
They're just counts, 47
yes.
Counts, okay.
Yes. So 47 is the N, and then the percentage is 81%.
Sorry. Yeah, sorry. Yes. So higher percentage of patients conceived who still had ovaries active before transplantation.
Correct. Yes.
Or is that active ovaries, like after you transplant it, they stayed active for a year?
Yeah,
I think it says ovaries still active before transplant. Yeah, clarify for me.
Yeah. So the way that I interpreted it was active ovaries for 1 year after the transplantation. So the way I interpreted it was they were describing the longevity of the transplantation.
But I didn't. It's odd to me that they compare individuals who had ovaries active before the transplantation to then determine if they have persistent function after transplantation. I don't see the utility of that. Am I not understanding this?
So the way that I interpreted it was patients who were more likely to conceive were the patients who had restoration of menses that was restored for at least 1 year after transplant. So maybe, but I guess the way I interpreted it was if they had restoration of menses, but it was not sustained, then that was less likely to be associated with a pregnancy.
Okay. Thank you.
Yes, of course. So just going back to the association with IVF, again, in this cohort, the majority of patients were not using ART, but among patients who did achieve pregnancy, those patients were more likely to have utilized ART compared to those patients who did not achieve a pregnancy. And then they found that there was no significant association between rates of need to transport the tissue overnight or exposure to pelvic radiation and chance of achieving a pregnancy. But again, just note that that less than 10% of the population was exposed to radiation, so those numbers are quite small.
Okay, one more clarification, Gabriela. Go back for me one more. So the IVF for yes, did use IVF and no. Patients with pregnancy, is it not greater percentage that did not use IVF?
So the overall cohort the majority of the cohort did not use ART to achieve a
Right.
pregnancy. But when they
Uh-huh.
subdivided the populations and compared those patients who were not able to achieve a pregnancy and those who were able to achieve a pregnancy, they found that those who achieved a pregnancy were more likely compared to those who did not to have utilized ART.
That's different from the other literature, right? That suggests that the higher percentage of pregnancies occur in patients who don't use ART but conceive spontaneously.
Mhm.
I think they still. Oh, sorry. Okay, sorry about that. I'm on like two different things because my speaker wasn't working. I mean, they are still saying that the majority of patients who got pregnant did not use ART.
That's what I thought.
Correct.
Okay.
Yes,
Yeah.
yes, correct. So again, 62% of these of the pregnancies were achieved in a natural cycle, but just when
Right.
they compare those two cohorts, they're saying that in the pregnant population, there was a higher proportion of patients who had utilized ART.
Okay.
So this unfortunately, this 62% is not presented in the table, but it was presented in their results. But I added it here for additional context because this can be a little bit misleading, which I think is what you were catching on to. Okay, so this table presents clinical pregnancy and live birth rates overall, as well as for the first transplantation and for repeated transplantations. And overall, they report that the pregnancy rate is 32.7% per patient. And in total, 64 women became pregnant. 60 of these women became pregnant after the first transplant. And women who achieved pregnancy after the first transplant were then excluded from this analysis of individuals who had a repeated transplant. So this cohort of patients after repeated transplantation only includes individuals who did not have success after the first transplant. So overall, they found that 30.6% of women achieved a pregnancy after their first transplant, and 11.8% who did not have success with the first transplant were able to achieve a clinical pregnancy with a repeated transplant. And the pregnancy rate was 34.5 at the time of the first transplant in the younger population, which was defined as less than 35 years, versus 20.4 in individuals who were 35 years or older. So now moving on to live birth rates, they report that the overall live birth rate in this cohort was 26.5, which translated to 52 live births. And the live birth rate after the first transplant was 25% and only 8.8% with the second or subsequent transplants if a pregnancy was not achieved within the first transplant. And the live birth rate after the first transplant for women who were 35 or younger was 28% compared to 16.7% in individuals who were 35 or older. And in the cohort of patients who underwent a repeated transplant after not being able to achieve a pregnancy with the first one, all of those live births were achieved in the cohort of patients who were younger than 35 years, and none were achieved in individuals who were older. So this is a graphical representation of clinical pregnancy rates over here to the left and live birth rates to the right as a continuous function. And overall, unsurprisingly, what we're seeing is that we have a gradual decline in both clinical pregnancy rates and live birth rates with increasing age. And importantly, we don't see a steep drop off at age 35. It's more of a continual gradual decline was what their data suggested. So the authors provided some examples based off of a logistic regression analysis. So One example that they provided was in women who are 21 years old. They expected the clinical pregnancy rate in that cohort to be 48% with a 95% confidence interval that ranged between 33 and 64, which corresponded with a live birth rate in this age group of 40. And they then used this model to predict outcomes in a woman who, for example, was 39 years old, where the clinical pregnancy rate for that individual was projected to be 19%, and live birth rate would be 15.7%. And importantly, this data is extrapolated as there were actually no patients in this cohort over the age of 38 who had had a live birth. So this table presents the data of women who underwent repeated transplantation with or without pregnancy after the first transplant. And overall, there were 34 women who had a second transplant after not being able to achieve a pregnancy within the first one. There were a total of 9 patients who underwent a repeated transplant after they had achieved a pregnancy after the first one, but oftentimes wanted to grow their family larger. So we see the results of those repeated transplantations here. So among individuals who had success following the first transplant, 44% of those had success following repeated transplantation. Whereas if an individual did not achieve a live birth after the first transplant, their overall chance of success was 8.8%. And again, these 3 individuals were all under the age of 35. So this was a supplementary table comparing characteristics and outcomes between centers, where they dichotomized the variable of volume of the center as having had 10 or more transplants performed at the center or less than 10 transplants. So the authors found that pregnancy rates after the first transplant were higher in centers who had performed 10 or more transplants, although that difference was not statistically significantly different, with a p-value of 0.12. And again, they report higher live birth rates in centers that were more experienced, but unfortunately, they didn't provide a p-value with regards to live birth rates. And this was just a graphical representation of that, where we see that they were finding what appeared to be an association where centers with a higher volume had a higher mean live birth rate, and that appeared to plateau around a volume of 10 transplants, which is sort of how they came up with that cutoff of 10 transplants per center. So what the data that they summarized was that on average, 1 in 4 women who are undergoing a transplant were able to achieve a live birth. With regards to prognostic factors, they found that age at the time of cryopreservation was an important prognostic factor with a continual decline with increasing age. They found that 30% of women under the age of 35 were able to achieve a live birth, as opposed to 17% of women who were 35 years or older. And again, the oldest woman in this cohort who was able to achieve a live birth was 38 years old. They also found an important relationship between number of transplantations. So the highest chance of success was with the first transplant, and individuals who were unable to achieve a pregnancy following the first transplant had an 8.8% chance of success with the second transplant. And importantly, all of those women were under the age of 35. But women who achieved a pregnancy with the first transplant, who then subsequently underwent another transplant to achieve another pregnancy, had overall high success rates of about 40%. They found that factors that were not associated with success were overnight transport of the ovary, And again, they found that both natural conception and IVF were both reasonable approaches for patients. The majority of their cohort achieved a pregnancy with natural conception, but they did describe that, that in patients who achieved a pregnancy, there was a higher proportion of patients who utilized ART. So just going over some of the strengths of the study, this was a study that overall had a large case number compared to prior studies. It was a multi-center study that used standardized protocols that were set out by the FertiPROTEKT network. However, some of the limitations included that it was a retrospective study that used registry-based data. They had a large volume, and as Matt had pointed out, each individual was, the stats were carried out per individual, but when they looked at the volume of the center, they were categorizing that based off of the number of transplants, not necessarily based off of the number of patients that, that they had seen. I think another important limitation was that in this study, at the time of ovarian tissue harvesting, in 84% of cases, they were removing 50% of one ovary. And I know that our institution at the time of harvesting, we're removing the entire ovary at that time. So that might affect outcomes. And then consideration as to whether your center is performing slow freezing or vitrification. Another important factor in this data set was that they didn't really comment on the patient's ovarian reserve. So information on their antral follicle count or AMH was not reported, as well as information on the diagnosis of primary ovarian insufficiency. With regards to eligibility for transplant, they reported that that was on a case-by-case basis, taking into consideration patients' diagnosis of primary ovarian insufficiency and their desire for fertility. Again, in individuals who utilize ART, we don't have any information on their IVF cycles and those outcomes. And with regards to pelvic radiation, it was a very small portion of their cohort, less than 10%, and we don't have any information on the fields of radiation or the dose of radiation exposure. And for future considerations, important considerations for patients, and as we continue to study ovarian tissue cryopreservation, is understanding factors that affect graft longevity. And the author suggests that potentially studying neovascularizing agents that can improve the revascularization of that tissue can be an important area of research in the future. Also, further understanding cryopreservation and thawing protocols, particularly differentiating between vitrification and slow freezing. And then for patients who potentially are not candidates for undergoing a transplant, or for patients who had leukemia where there's concern of reseeding any malignancy, discussion of future potential for in vitro maturation is another consideration down the line. And so with that, I'd like to open up the discussion and answer any questions.
Excellent presentation, Gabriela. Really, really nice. Thank you. All right. And thank you, Matt, as well for the statistics. All right, Joy, please. Do you want to come off mute and ask a question?
Yeah, so one comment was, I don't think they looked at this, but like a lower age, was that effective? Like, did they look if they were prepubertal versus postpubertal at time of ovarian tissue freezing? I don't think they did.
Yeah, that's a really great question. They did not. They didn't really comment on the youngest patient in the cohort, rather just the oldest that was able to achieve a pregnancy, who was 38. But I do think that is a really interesting question. And as I noted with regards to the graph that they presented, looking at the association between age and live birth rates, this data was extrapolated. So again, hard to really, there's a lot of limitations to using this data since it's all extrapolated information. But yeah, I agree that it's certainly a limitation that they didn't include further information on the younger cohort.
And then this is kind of my lack of knowledge with retransplantation, and others on the call probably have more info. I thought the best way for transplantation now, was to put it back, most people were putting the tissue back on the other ovary, and it sounds like most of these were put in a pocket. But again, that's really outside my area of expertise, and I didn't know if somebody else could comment on that.
Glenn, are you commenting?
Yeah, thank you, Leslie. Sorry, I was in the operating room when I missed the first half, but I did hear Gabriela give this presentation as a practice before. I find it interesting that there's a lot of discussion regarding prepubertal tissue. And the only thing different about prepubertal tissue is the HPO axis isn't activated, but ovarian function and ovarian reserve is excellent in prepubertal girls. So I would not imagine that you put this tissue back from a prepubertal girl into a girl when she's gone through puberty and adulthood. The tissue should act normally because the primordial follicle pool is excellent. So, I don't think that you can. Yes, we only have 2 patients that I'm aware of from prepubertal tissue that have had transplantations, but the tissue should act exactly the same. And where you put the tissue is not really relevant. In fact, at ISFP recently, there was some really good case reports of natural conceptions from peritoneal pockets. So tissue put back into peritoneal pockets, as long as there's a tube on that side, even if there's no ovary on that side, you actually have successful outcomes in terms of natural conceptions. You don't need IVF when you put it back in the peritoneal pocket. So where you put the tissue back is not as important as the quality of the tissue when it's put back inside the person.
Yeah, and Joe, I believe that the data that's published says exactly what Glenn has just shared, that the pregnancy rates have been equivalent with peritoneal pocket versus decorticating the remaining ovary and suturing it back or creating those little slits. The data seems to be about equal with that. And to support what Glenn is saying too, and I think we would expect, I think, higher pregnancy rates in the prepubertal patients because there are more follicles, right? The tissue is smaller, so maybe there's some loss of integrity with vascularization, but there's still more follicles left for potential. So I would anticipate they would be higher. And Glenn, thank you for clarifying that the tissue is going back where the ovary has been removed. There's been some discussions on our side,
okay. I was like, how do you get naturally pregnant in a peritoneal pocket? Okay, that makes more sense, because I was like, how do you get naturally pregnant if it's just in the pocket sitting there, not connected to a tube? Okay.
Yeah.
Thank you.
As long as there's a tube on that side, there's a pregnancy, so you don't have to do IVF if it's a peritoneal pocket. So I would,
okay.
Yeah.
Okay, that was my lack of understanding of anatomy of where the peritoneal pocket was. So thank you for that. I'm always learning more with my, I'm an oncologist, so I will specify
But Joe, I think it's still even remarkable that it just ovulates through the peritoneum. I mean, let's be honest, even that,
yeah,
is remarkable to even think about. So, okay, someone had a question they couldn't put in the chat. So a couple of years ago at SRI, Richard Anderson presented some data about pregnancy rates for cancer survivors who did not undergo OTC or who had undergone OTC and not had the tissue transplanted back, and that there was a good pregnancy rate. Does anyone have any more intelligent commentary about that? Anybody remember that publication? I don't know, Gabriela, if during your research you came across that, right? There's always that discussion about, should we be doing these things because many patients will conceive anyway, but it's going to really, I think, go down to prognostic factors. Who are those patients? Are they patients who are prepubertal and had many follicles to begin with? Did they receive lower risk therapy than initially anticipated? I think there are a lot of unknowns about who those patients are, but I don't know if anyone has some thoughts on that. Because I think there's some people who still believe that individuals are conceiving from the native ovary and not necessarily from the transplanted tissue, which is why I wanted to clarify that point about the persistence of the ovarian function. But any commentary on that?
Yeah, Leslie, if I can, I don't know if Gabriela, she said this when she presented it last time, but I think we need to reserve ovarian tissue cryopreservation for those who will likely need the ovarian tissue in the future. It should not be used for the Hodgkin's lymphoma patient getting ABVD because their risk of
Right.
ovarian failure is almost zero. I mean, it's really low. So
Yeah.
I think if we reserve it to people that have an over 50% chance of complete ovarian failure and a
Mhm.
over 50% chance of a 5-year survival that are going to use the tissue, that are under 35 or 38, depending on, you know, where you draw the line, those are the people who really should be reserved to have the ovarian tissue cryopreservation done. Now, if you're not menopausal, yes, you will have pregnancies afterwards. So that just is, that's nature. But the transplantation should only be done in people that are truly menopausal and cannot achieve a pregnancy with their native ovary.
I agree with that. I think what I find hard is the 50%. You know, our risk stratification tools don't kind of do a categorical, is it less than 50 or greater than 50? It's, you know, less than 20, 30 to 70, greater than 80. It makes it a little bit difficult, but as someone who does this often, we have a gestalt of what is greater than 50% when we see the patients agreed.
Anybody getting a transplant, you know they have a high risk of ovarian failure. They're the ones that really need the tissue transplantation.
Yeah. And we tend to be conservative with our OTCs, and we tend to perform them in patients at that highest risk category, unless there are some other confounding factors, particularly for our adolescents who may have function and survivorship and may be able to undergo egg freezing. If they're kind of on that cusp between significantly increased risk and high level increased risk, I would rather not remove the ovary if they think that they might be able to undergo oocyte stimulations, ovarian stimulation. Some patients, they know they will never be able to afford that. They think like that is way not possible for us, and they would rather us remove the ovary, even if they're in the kind of the significantly increased risk, but on the higher side. So that's how we've been doing that at our institution. I don't know if anyone else.
And if I can ask a question to the group and to you, Leslie, also, if we have a patient who has time to freeze eggs, let's say they have 2 weeks, but they want to freeze eggs and they also want to freeze ovarian tissue, how would you approach that? Because I know I feel a certain way, but how would you approach freezing eggs and ovarian tissue in the same person before they get their chemotherapy?
So I'll give my answer and then everybody else can reply. So we've done that in a patient who was going to have enough time for the ovary to kind of go back down to its a more normal size. Otherwise, we worry about how we're going to remove a stimulated ovary laparoscopically. So if they've had time and we think that the ovary is going to go down, and hers did, and then we were able to do that because of the time that we had. She wanted all potential options. What is everyone else doing?
I don't
I
think
raise
I've
my
had
hand.
that come up, so most of my patients choose one or the other.
Yeah, Glenn, what
So
are your
we've done
thoughts?
ovarian tissue first, and then we did ovarian stimulation after, because yeah, it takes, well, if you give a Lupron trigger, probably 4 to 7 days before the ovary comes back down to normal size. And then you got 2 more weeks of stimulation. And most of our patients and most of the oncologists we work with that's 2 weeks is okay, but 3 weeks they're not okay with.
And you feel good about the fact that you'll just have fewer follicles because there's only one ovary that you're stimulating, obviously. Yeah, any potential to partially stimulate first, remove one ovary, do IVM with partially mature follicles from that, and then also do ovarian stimulation and retrieval. I mean, we should just get as fancy as possible.
So I think that came up when Gabriela was talking about, doing IVM from follicles in the ovarian tissue. And, you cap IVM on the follicles, freeze the ovarian tissue, and you can also freeze in vitro matured eggs at the same time. So that's an option too.
Cassie, what do you think? You do most of it. I'm just talking theoretical here because I give you the stuff and you do what you do, but any thoughts?
Yeah. Oh, sorry. Sorry about that. I think we've like attempted that once in an ovarian tumor, where we were trying to collect immature follicles at the time, without intention to actually freeze that tissue since we saw tumor in it. I think right now with the IVM, like this literature is super helpful because it's good to see, like, have actual data on pregnancy rates and what people can expect more. What I hate doing is saying like, well, we have this as a maybe, we're hopeful the technology's there in the future, but like, I always hate like the false host aspects if I'm not really sure, like, will we have the technology to use this? And we're doing all this preparation and involving a lot of people, right? And ultimately like patients are paying too. So um it's nice to have like a different group, different network now than just coming out of Israel showing reproduction of live births and everything. So but I still think, you know, the way we've got here is by pushing the envelope forward. So I think if you have the capacity to get all those people on board for those kind of more difficult cases, or the ones that seem, you know, hard, I think like IBM, there are places that are working on it. So that could be more of something over the next 10 years for sure. And I think that is definitely something you could do. Just you could give like an HCG trigger, you know, but 36 hours before the surgery and see, are you going to get anything like at all from those little follicles at the same time too. But it just, as like we've experienced, can sometimes just require a lot of coordination, which can be hard to do last minute. But I think if you can, certainly worth trying.
And then
Hi,
Glenn, for
Anna
patients
from
over
Univer.
35. Oh, sorry, go ahead, Sana.
Hi, sorry. Very nice to meet you. Thank you all. I just want to, IVM is really a technology that's coming more and more into our field. There was just an article that my chair sent to me about a company, I think, and I'm not part of like conflict of interest or anything, but it's called Fertility, and they try to culture those small little oocyte with, I think, ovarian support cells that's made from pluripotent stem cell. And I think they have a technique that's patented, and they're kind of offering this for clinical kind of use. So yeah, we just have to watch out for these things coming in.
Yeah,
For sure.
Gabriela, I think you guys talked about that. We had a journal club about that a while ago. So there's two companies out there, Kappa IVM and Gamito.
Okay.
And there's definitely a difference between the two. And certainly I think there was at ISFP, there was a lot of buzz about Kappa IVM. And that certainly I think has been shown to have pretty good in vitro maturation of not germinal vesicle follicles, but of immature eggs like M1s and GVs. So, Gabrielle, any comments about that?
I think you covered most of it. Perhaps one of the other fellows had presented on that for Journal Club. Yeah. Sorry. I did have one more question. Sorry, going back to the younger prepubertal cohort. Matt had added in the chat that the youngest patient that they included in this study was 17. And I know that when we counsel younger patients who are undergoing controlled ovarian hyperstimulation, we know that younger patients do have higher rates of aneuploidy. Dr. Chapman, how do you sort of counsel patients who are prepubertal who are undergoing ovarian tissue cryopreservation? And we know that those patients probably have very high rates of aneuploidy. How do you counsel them regarding rates of aneuploidy at the time of transplantation, if maybe 10, 15 years later they decide to do that?
So I think what's really interesting in this population is any ovarian tissue transplants, as you mentioned before, you lose, I mean, it's by some estimates between 70 and 90% of the primordial follicle pool. So you're essentially aging the ovary significantly when you put the tissue back. So I think the 6-year-old or the 8-year-old who you're freezing ovarian tissue on, when you put it back, is no longer the same 6-year-old ovary when it gets back and when it gets revascularized. So I don't know if we have any data, but I would say that probably it's not going to be higher than anybody else because you've had such significant primordial follicle loss and you've aged the ovary that you're probably not in that age category anymore.
And is that aneuploidy more likely to result in lack of fertilization and like early loss rather than a malformation, right? It's the type of aneuploidy we're discussing.
Yeah, it's interesting. Miscarriage rates in young girls are actually higher. People think, oh,
Yeah.
16 or 17, it's better. It's actually not. In fact, I think I don't even tell people to freeze eggs for planned fertility preservation until they're at least 26, if they have no other reason to do so. So it's not a good college graduation present.
And then in terms of the thought about the repeat transplantations, is it just as simple as if you don't conceive with the first transplant, then maybe the ovarian reserve is low in the tissue to begin with, and that's why you're less likely to conceive after the second transplant? Do we just think it's as simple as that?
I also had a follow up, Dr. P. I also had a follow-up question with why the indications for even doing a repeat transplantation. Like, is it just so they could get a live birth, or I guess like why do it in that case? That was my question. But
Yeah, I would think it's to have a live birth. If they don't conceive with the first one and they have, 15 tissues overall, they're going to want to try to exhaust all of them to try to conceive. So that would be my understanding, that it's just because they're trying to have a live birth. And then some patients, obviously, once they conceive, they also want to conceive again. So that would be my understanding. Is that your question, Simone?
yeah, I guess because and Gabrielle, great job on this presentation. I think like the first table or whatever, it mentioned that like 65% of patients have resumption of menses. And yeah, I was just curious as to why a lot of these women, not a lot, but like a good subset of these women had up to like 3 repeat transplantations. Like, I guess like what a global question, like what is the indication for repeat transplantation? Is it, I'm assuming also to try again for a possible live birth, but is it for menses? Is it for kind of like a hormone replacement therapy? But yeah, I wanted to ask that to the group too, but we only have a minute left, so.
Hey, Simone, I haven't seen
Hi.
you forever.
I know. I look really terrible, so that's why I don't have my camera on.
Well, I'm in the OR. So the repeat transplants were people who had a transplant done, the tissue failed, they didn't get pregnant, or they got pregnant but it's once the tissue fails and they want to have another pregnancy, the tissue is put back for a second transplant. But that's why the repeat transplants are happening. Now, if you're having a transplant 2 years after the first transplant, it's because the tissue wasn't great to begin with, and it only lasted, 1.5 to 2 years, then it stopped working. So that's probably the majority for the repeat transplants.
Oh, got it. Okay. That makes sense. Thank you.
And I think, like you mentioned this in the limitations of the study, that they didn't mention what the AMHs were prior and everything. So you could assume that somebody who has a lower AMH is going to have, a less proficient graft. So they're going to have less longevity of that. So they could need transplant more quickly. And I think keep in mind, like all these little cortical strips, might react differently to the freezing process and may have like more or less primordial eggs. So you would hope that it's like somewhat equivalent between them. But there can be batch to batch variation too, so.
Got it. Yeah, that makes sense.
So I think did you mention, Gabriela, that it takes about 1/4 to 1/3 of the tissue to go back for these transplants? So you only get 3 or 4 transplants. One little strip of tissue is not going to do it.
Yeah, I didn't mention that specifically, but importantly in this study, 84% of the patients only had 50% of one ovary cryopreserved. So smaller pieces of tissue than I think that we traditionally do here when we remove the entire ovary. So that might also contribute to a shorter longevity of the transplant.
And Glenn, I'm still a little bit at a loss of these individuals who don't use cautery or heat coagulation to remove the ovary. Like, I get that in a pediatric patient where people use they do the loop and then they tie it off. But I haven't met an adult whose pedicle is small enough for me to throw or feel comfortable throwing a loop around it when they have to go to chemotherapy and I can't risk bleeding. So I'm doubtful of that technique.
Yeah, I feel exactly the same way, and I don't know, as long as you're not cauterizing the ovary, I don't.
Yeah.
es-
And give it a
Especially
little bit
small,
of room.
yeah, small ovary, when you take a small little biopsy or a piece of the ovary, that's not really enough tissue. If they have a high risk of
No.
ovarian failure, you're not really getting anything. So
Yeah.
I think if you get a good enough pedicle and your cautery is far enough away and use a
Yeah.
vessel sealer, that makes me a lot more comfortable, especially
Mhm.
when there was a case report of where was it done? It was, I think, somewhere in Pennsylvania, somewhere where the girl actually almost died after having a part of an ovary taken out, and then essentially, bled out, after the surgery, not immediately after, but once they started chemotherapy, they became pancytopenic.
Mm-hmm. Yeah, and I think I think we're doing the patients a disservice by doing a partial oophorectomy or cortical strips. I think it's wrong. I think that if you think this patient needs a laparoscopic procedure in the prior to chemotherapy for fertility preservation, then you need to get as much tissue as possible so she can actually have a chance at a live birth. And I think people's anxiety and uncertainty about their risk stratification or their indication for doing the OTC is a problem. I feel that if you are so cautious and so worried that you're making the wrong decision, that you want to leave part of that ovary, I don't think you should be doing that. There's an entire ovary remaining. If there's going to be function, why not rely on that? But to cauterize part of the ovary is already damaging to the ovary. So I think it's wrong, personally. I think we need to stop allowing that for our patients. I don't think it gives them the best options in the future. Debate. Okay. All right. Thanks, everybody. I know it's 12. Thank you so much. This was excellent, Gabriela and Glenn. Thank you for your mentorship of Gabriela through this project, and Arzu and Matt as well. Have a good rest of your day, everybody.
Thanks, everybody.
Thank
take care.
you. Bye-bye.